Ever since Patricia started taking EpiJoint, which has that new ingredient Epitalis in it for mild arthritis, she's got a whole new lease on life. Even discovered a passion for blacksmithery. She makes horseshoes, medieval armour, and her favourite, the mace collection. She's out the back making a ceremonial claymore right now. Yep. She's never been happier.
Hi everyone, and welcome to tonight's webinar. My name is Michaela and I'm a part of the team here at Musculoskeletal Health Australia. Before we begin, and on behalf of Musculoskeletal Health Australia, I would like to acknowledge the traditional owners of the lands from which we are broadcasting from today, and to pay our respects to the elders past and present. Tonight's webinar will discuss something that no doubt almost all of us are familiar with: pain. In particular, our presenter will look at how our perception is relevant to how we understand and treat pain. He will also discuss how this impacts on our musculoskeletal health, along with some of the latest scientific insights in this area. Our presenter is Dr. Daniel Harvie, a physiotherapist, a pain scientist, and the director of the Masters of Advanced Clinical Physiotherapy at the University of South Australia. His research has mainly focused on new approaches to chronic pain using virtual reality and modern understandings of sensory processing. We're so very grateful to have Dan present this webinar, and we hope you enjoy.
Well, hello and thank you very much for joining me. I am Dr. Daniel Harvie. I'm a physiotherapist, currently the program director of the Masters of Musculoskeletal and Sports Physiotherapy here at the University of South Australia. I have a clinical background, also a PhD in persistent pain with Lorimer Moseley. So that's the perspective I'm coming from, but I thought today I would focus on pain from the perspective of someone who has delved pretty deep into the perceptual science literature and fairly recently written a short book on pain from that lens with Lorimer. That's what you see on screen here. So that'll somewhat be the focus for today. My thesis for today up front is that musculoskeletal health must not only be about being in good physical condition, but also about feeling in good physical condition. So this relates to whether you feel comfortable or whether you're in pain, what your energy levels are like, whether you feel stiff, and certainly whether you feel like you can trust your body in a way that lets you move and do things that you want and need. However, how the body feels can diverge quite significantly from the physical state of the body itself. And this is a truth that's been revealed in part by the modern pain science literature, which I've been a small part of. There's a fairly popular idea now that our experience of the world, our experience of our body, is something of a controlled hallucination. This has come about in really recognition of the complexity of human perception and the clearly strong role that the brain plays in interpreting sensory data and in creating those feelings and sensations that we have. So a simple way to think about how perception works is that we have inputs, whether visual, somatic, auditory, etc. And that these are important, but that these are filtered and processed. And that's in part with reference to stored data and past experience. And it's only once those inputs are processed and the brain makes sense of those on a subconscious level that we end up with the conscious experience that we have. Those experiences of pain, vision, sound, what have you. But Of course, I say that with a warning, because the idea that our experience or pain is something of an illusion is a very philosophical point. It doesn't negate the stark reality that pain is real 100% of the time, regardless of its cause and regardless of the complex processes that underpin it. So if you relate to what I'm saying here, what I don't want you to feel like is that I'm saying that pain is somehow all in your head or not real. Pain is always real. All I'm saying is that it's complex, and that as much as the body always has something to do with it, so does the brain. So a little bit of an outline of the next part of the talk. I'm going to share 3 pain facts that should flip our understanding of pain. I'm going to talk a bit about perception and how perception works, because if we can understand how perception works, we get a better idea of how pain works. I'm going to talk about how illusions can help us understand both perception and pain, and tackle the idea of whether illusions can actually help us treat pain, before finishing with some implications from these ideas in regards to how we best manage pain, and particularly those persistent pain problems. So let's start here. 3 key pain facts. The first one here is that pain and the physical state of the body are poorly related. If you've ever heard a talk from me, you've probably had me do this with you, but indulge me and do it again. Go to the list of imaging findings in the left-hand column. Pick whichever one feels the scariest to you, and then go across to the column that coincides with your age. So I've just gone 40, so for me that is the 40-year-old column. Now you will see a percentage there. Now that percentage is the percentage likelihood that someone in your age bracket would have that imaging finding, even if you had no pain whatsoever. So this data comes from several thousand people who have no pain whatsoever. So this already starts to paint that picture that pain and the physical state of the body, certainly what we see on scans, are different. They can diverge. You can have these findings and no pain. You can also have lots of pain and have none of these findings whatsoever. Furthering this idea that pain and the physical state of the body are poorly related are some stories. And in this case that was reported in the Brisbane Times, he said the most I felt was his body hitting me. So he reported pressure, but not pain. So this is one side of the coin where people can have a lot of tissue damage, but not experience pain at all. On the other side of the coin, we have cases like this. This was a case reported in the British Medical Journal where a builder jumped on a nail and he was writhing in the most unbearable pain. When the ambulance arrived, they took off his boot, however, and found that that nail had actually gone between his toes and there was no physical damage whatsoever. So this is the other side of the coin that shows us not only can you have a lot of physical damage but no pain, you can also have no physical damage and a lot of pain. So perhaps the best way to think about pain is as a protective response. Pain is to some degree about those inputs from the body, those nociceptive inputs, but there's processing going on to make sense of that and also to prioritize whether a protective pain response at this point in time is helpful or unhelpful. And only then do we have a conscious experience. And the third key point about pain that I want to share is that it's an adaptable system. And here we have the analogy of the well-worn path. And it seems to be true that paths that are well-traveled within the nervous system also become something like well-worn paths that get more efficient and more effective with practice, such that pain becomes more easily produced over time. And of course, the term for that is sensitization. So that brings me to the part of the talk about perception and some of the rules that govern perception so that we can see how those rules might apply to pain. And for this section, I'm going to be using some of the images from the book that I wrote that's available at noigroup.com, and they have graciously allowed me to use those images in talks like this. So one of the rules that governs perception is that our brains are naturally grouping data from different sources. And so this is why we have effects like this, where we naturally see things like faces where there are none. So the brain is sort of hungry to create meaning from sensory data. Here we have two grey boxes, and if you're like me, you'll see the top one as significantly darker than the bottom one. If I block out the background, however, you'll see they're actually exactly the same shade of grey. So what this illustrates is that our perceptions are something like the answer to a question. The question in this case is something like, what colour are these boxes? Our brain is always asking these questions subconsciously. In order to make that decision, the brain is gathering information from the specific locations, but it's also gathering other data from the surrounding image, the context. Things like where the shadows are, where the light source is, and it's putting all of that information together to judge the shade of those boxes. When it comes to feelings in the body, the brain is similarly interested in information from particular locations, but it's also interested in the rest of the picture, the context. And that might be things like stored information in the brain, beliefs about pain. It might be things that they've been told, maybe from health professionals or things they Googled on the internet. That might be part of the context that's providing information to the brain. And so it's not just that location-specific information, just like with vision, but it's the whole picture. It's all of the information, the data that the brain can put together that influences the final feeling that we experience. So perception and pain are sort of like the answer to a question. In the case of pain, though, the question is something more like, is my body in danger and do I need protection? Perceptions are also heavily influenced by expectation. Take a look at these three faces. You'll see they look relatively normal. However, if I flip them over, you'll see that they look anything but normal. The reason that they looked relatively normal when they were up the other way is because I flipped the eyes and the lips upside down. And so until I turned the image 180 degrees, the face looked sort of as though the brain expected it to look. But when I flip it over, your brain detects that there's something there that violates its expectation. Expectation, of course, is also important in pain. It underpins things like the placebo effect and the opposite of placebo, which is the nocebo. So expectations are important for all of our senses, including pain. The next one, I think the final one that I'm going to share today, is that part of the processes that underpin our sensory perceptions includes filling gaps. Hopefully this comes across nicely on your screen. What I see in this is a light blue circle. And even in the middle of that blue circle, I see blue. I see a nice line that defines the outside of that image. But in fact, there is no blue circle in that image at all. There are only rings like these ones that I've displayed on the left. So if you're seeing this as I'm seeing it, then your brain is filling in the gaps. It's assuming that there's a whole unified blue circle here. The idea that the brain fills gaps, I think, is even more important when it comes to pain and feelings in the body, because unlike vision, which is a very precise sense with a lot of high quality, high resolution sensory data, there's relatively less data coming from the body. It's more imprecise. And so our brains have to do a lot more work to interpret that and make sense of it because there's simply less of it. So I think there's more room for the role of the brain when it comes to pain than even there is when it comes to vision. Cool. So that's a bit about how perception works through the lens of illusions. But I and others have also been using illusions in the research context to probe the nature of pain further. And I kind of think that the ultimate illusion can come from using virtual reality. So virtual reality is that replacing of the real world with a digital one. And of course, we can replace your real body with a digital one as well. So from those two things, we get the place illusion, that feeling that you're really somewhere where you're not, and this idea of a body ownership illusion where you feel like you are something that you're not. This gives you a sense of presence and what we call embodiment. My first use of virtual reality to probe some of the nuances of pain had people with neck pain wear a VR headset, turn their head to the first point where their neck pain increased and to stop. But I made it look like they were moving more or less than they actually were with a virtual reality trick that looks like this. So you'll see me turn that virtual reality headset about the same amount each time. But what you'll see is that the amount of actual movement that they see on the headset can change dependent on the software manipulations. And when we did that, we found that if we made it look like they were moving less, they could move more before pain came on. And when we made it look like they were moving more than they actually are, their pain came on sooner. So this was a group of people with everyday musculoskeletal neck pain, and we were able to show that their pain with movement was dependent on more than just what was happening in their body. So we can put that idea into this model that I've been sharing with you. The inputs from their body weren't necessarily different, but what was happening in the brain, the way the brain was gathering data from the eyes and making sense of that with regard to whether the body needed protection, and then factoring in that visual information about movement when determining whether pain was needed as a protective response. So I think illusions can help us understand pain, and the next question that I have is, can illusions help us treat it? Now, I know I'm running out of time, so I might skip through this a little bit, but my first contention is that illusions can help us teach people about pain, because they show so clearly to us that what we see, hear, feel is dependent on more than just the physical state of the world or of our bodies. Illusions, however, can also, in some cases, help us treat pain, and the flagship example of this is mirror therapy for usually phantom limb pain, but there's also some other ideas around like virtual reality body image training, which I'll mention briefly, being able to do graded exposure in a simulated way for people who are so sensitive that they just can't get started on movement in the real world. Illusory walking is something I'm involved with, trying to help people who have a phantom type pain in their legs that they can't use. So we have people swinging their arms, holding virtual reality controllers, which trigger their virtual legs to start moving, and people report a real sense that they're actually moving, even though they know that they're not. And that is seeming to have an analgesic effect. So let me just share a little bit of work. This was a study based on something called the Proteus effect, which is the tendency that we have to adopt the characteristics of an avatar, a digital body, if we embody it in virtual reality. And my first use of this was with a 45-year-old male with a 5-year history of some pretty disabling back pain that started after he fell from a first floor deck. And what I had him do was to embody some very fit, very strong looking characters. He boxed, he became the Incredible Hulk, and he did rock climbing. To give you a sense, the boxing looked like this. So we always started with some movement, using the eyes to take in the body and really start to feel like that is them. And then we always get people then using the virtual body in a way that helps to embody not just the way the body looks, but to embody the character, that strong, fit, capable character. When we did that, what we found by asking him how he felt, whilst before going in virtual reality, he felt weak, lacking agility, vulnerable, and not very confident to move. When he became those characters, his sense of himself, his confidence in his body really spiked. And we also noticed even on session 1 that feeling tended to hang around a little bit after he came out of virtual reality. And when we repeatedly had him do these tasks in virtual reality, we found a similar effect. So we sent him home with a headset and we had him do this fairly intensely for 7 days. And what we found was that after doing this task intensely, this feeling that this increased confidence in his body seemed to remain improved. What we also found was that his pain changed fairly well in line with how his sense of his body was. So when his confidence in his body went up, his pain also went down. And what I've plotted here in blue is his current pain, and in white his average pain over the previous week. So he started around a 5 or 6 out of 10 as an average pain rating, and by the end of the study he was hovering around a 2 or 3. So let me leave you with some parting thoughts. Thinking of pain as a phenomenon of the brain, as we have done today, doesn't negate the importance of the body and things happening in the body and understanding and treating it. However, thinking of pain in new ways and from new perspectives, I think can really serve us and help us to better understand particularly cases where pain doesn't seem to match with the state of the tissues of the body. And this newer way of thinking about pain can also help us think more holistically about management and treatment, and help it to make sense that people need to look beyond what's on their X-ray or their MRI. And so in that light, management should move in general from an approach that purely focuses on damaged and unhealthy tissues to thinking more broadly about how can I desensitize my body, or how can I improve its resilience? How can I regain confidence and ability to move? And so what do I think are the best tools to facilitate this process of desensitizing the body and nervous system and improving resilience, regaining confidence in the body? I think it's always going to have to involve movement of some sort, and graded activity is very often going to be at the center of that. And part of that, I guess, is getting fitter. It's building resilience in the body, but it's also desensitizing the nervous system. And so I think the most important part of graded activity is to grade your activity in a way that doesn't produce flare-ups. And that means getting the starting point right, and also the rate of advancement right. I think too many people give up on movement as a strategy because either it flares them up, or they don't see progress. And in order to see progress, you need to find this Goldilocks zone of activity which pushes you a little bit and helps you build resilience and desensitize, but doesn't cause these flare-ups that can maintain a cycle of pain and sensitivity. Also, if needed, and this is individual, addressing mental health issues, stress, sleep, all really important for helping to calm the nervous system. So thinking about this brain-body connection and addressing those things is very, very important and always part of the picture. And indeed, perhaps there are some specific issues that need to be addressed in the body, and sometimes it's important to reach out to a physio or other health professional to get specific advice on those things as well. And as a general rule, looking to what we call active strategies over passive strategies should form the core part of recovery from pain. So active strategies are things where you have to do something, move, meditate, change sleeping patterns, diet. These are active strategies that require you to do something, and these are the things that are going to drive positive change in your body and in your nervous system and in your immune system over time. Passive strategies can be part of your management plan. These are things like medications, heat packs, massages. They can be really useful in helping manage symptoms and helping you get on the road, getting started on active strategies. But that's not a domain of treatment where you can hope to see long-term progress. So focus on active strategies, get moving at the right rate, and address general health issues is the best advice that I can give you today.